So yeah, thanks everybody for joining this FCI webinar. We're delighted to have Amir Mehrkar and Ben Goldacre with us, discussing their OpenSAFELY work. So I've got a little bit of housekeeping just up on screen that I'll go through quickly, and then I'll hand over. So if you could all keep yourselves muted during the presentation, and then we'll have the Q&A session after the presentation. Please ask any questions you have in the chat box throughout, and we can get to them then. It is being recorded as well to watch back on the faculty website and YouTube channel. So I think with that, I'll hand over to you, Amir.
Thanks very much, Joe, and everybody. So, yeah, my name's Amir. I'm a GP in Hampshire and known to some of you for co-founding the Interop Summit with Wai Kyung Wong and Kian Hughes, two other founding faculty members, and alongside David Stables and Paul Cooper from Tech UK, the three of us founded InterOpen to bring industry together to develop Care Connect fire profiles. So breaking down information silos, which includes making informatics education more accessible to clinicians and working with partner organizations to co-produce those solutions openly, has been a core value of mine since my shared record days, encouraging vendors in particular to adopt the Robin Hood principle of information sharing, i.e. the information rich having a duty to share with the information poor to improve patient care. And it was after a late evening perusing TED Talks that I happened upon one of Ben Goldacre's ones, and I didn't really know Ben before. So listening to Ben's account of how he and his team had championed the importance of open and transparent research studies, the sharing of all research findings, positive or negative, and the breaking down of silos, I decided to send Ben a cheeky email at 1 a.m. And I wrote, I really believe the future successes of health tech needs a shift of power from the center towards the local areas, those on the ground, clinicians, patients, techies, and ethical vendors, enabled with money, tools, and people to solve real local problems. It wasn't the most exciting pitch of 1 a.m. email, but I did get a reply 3 months later. I still have the email and the reply. And after an eventual lovely 3D initiation ceremony stroll, I was lucky enough to be invited to join his team at the Data Lab. And the team really are amazing. It's clinicians, techies, and we're ethical vendors. You know, we're an ethical vendor. We make stuff, but actually give it away for free. And it was serendipitous that I joined when the OpenSAFELY concept was born, but being there from the start has really only strengthened my belief that size really does matter, and big isn't always that great, that an environment that welcomes curiosity, questioning, challenge, and in particular assumes trust from colleagues from the outset fosters high performance, and that building effective solutions is truly about a multidisciplinary approach and really working hard to put aside organizational egos. So it is with great pleasure I hand over to Dr. Ben Goldacre, Director of the Data Lab at the University of Oxford, to describe how we built OpenSAFELY, how it works, and how it can positively change the face of NHS research. So over to you, Ben.
Hey, well, look, thanks for having me, and don't tell HR about my recruitment strategy. Is there any possible way that I could invite you to switch your cameras on if you feel comfortable with that? Just so that otherwise it's a very lonely and strange experience talking to people where you just can't see them at all, only if you wanna. And if what I'm saying meets your approval, if you could wiggle your hands in the top half of the screen, that'd be great. And if you're appalled, then wave your hands in the bottom of the screen, and then at least I know if I'm losing the room and saying things that make you cross. And also, before I start, can I just kind of quickly sense check? Faculty of Clinical Informatics, great thing, broad church. Some of you kind of project manage installations of large EHR systems. Some of you are sort of hardcore technical, know about how medical data works in the meat and drink and can write a line of Python. Some of you write social science essays about how people interact with technology, that kind of stuff. Is that roughly right? Tell me who's in that. Tell me who's not in that list, who I'm missing. Angela Davis.
Education. So I'm interested in this project because we're trying to integrate EHRs into our undergrad education at Manchester.
Ah, great. Okay, good. All right. Well, look, and hopefully we'll get at the end to talk a little bit about how working in the open is actually a really powerful tool for helping to build capacity in the workforce for better use of data. All right. So look, I run a group called the Data Lab at the University of Oxford, and we're quite an unusual, truly mixed team of software developers, traditional academic researchers and clinicians, all pooling skills and knowledge. And we're quite unusual in an academic setting in that we do produce peer-reviewed academic journal articles to be read by almost nobody, and that's the core business of universities. But we also take large health data sets and turn them into live, interactive, data-driven tools and services using exactly the same skills, because you need to understand medical stats, epidemiology, electronic health records, but also software development to do that. So a project that some of you might have heard of is Openprescribing.net, which gets about 15,000 unique IP address users a month, 130,000 unique users a year, lets you see what every individual doctor in the country or every individual GP practice in the country is prescribing, down to the level of individual doses and brands of individual drugs month by month, with lots of clever data science under the bonnet to help you spot opportunities to improve quality, safety and cost effectiveness of care. We also build things like the trialstracker.net projects, which are live audit tools to spot who has and has not complied with the EU rules and the US laws requiring you to report the results of your clinical trial within 12 months of completion. And that's not a manual audit. Those are automated services that scrape PubMed, scrape clinical trial registries, embed the law in code, and then evaluate it and give actionable insights back to people. When COVID hit, we realized that the world would probably benefit from some very large-scale data science. We realized that it would require much timelier access to data and much larger data than people had traditionally managed to make available for research purposes. And so before we start on the kind of technical details of OpenSAFELY, I think it's worth thinking that through. Patients' GP records, as everyone here knows, in the UK are stored electronically as a list of event codes. And those records are very commonly used for research projects, academics wanting to know whether patients from one ethnic group are more likely to get diabetes or less. And conventionally, researchers would work on intermittently extracted records, pseudonymized downloads, and we'll talk in a moment about what pseudonymized actually means in practice, for a few million patients, like the GP research database, now rebranded as CPRD, and through a conventional research data service. Now that data is commonly many months out of date when it becomes available for research, and that's no good. In evaluating a new rapidly arising cause of death like COVID-19, you need data quickly because it's a novel cause of death, not been seen before. COVID-19 arrived suddenly and rose in prevalence very rapidly. And the first wave of COVID-19 would have come, peaked and gone away, I think, entirely before any cases appeared in most conventional GP research databases. In addition to that timeliness of data, you also need huge numbers of patients in a research data set if you want to understand the different risks from COVID-19 in smaller subgroups of the population. So, for example, if you want to understand the different risks in people with hematological cancers and non-hematological cancers, then very tragically, you need enough deaths, or at least enough expected deaths, in each group to be able to assess a statistically significant difference between those two groups. And it's the same story for understanding the change in risk among people on a given drug. Let's say there are 100,000 people in the country taking a drug, and 1 in 2,000 people in the country have died from COVID-19. Then if your research sample takes in only 10% of the population, that's 6 million people, 5 million people, you have an expected 5 or 6 deaths among 10,000 people taking the drug in your sample. And for your statistical models, that's going to compromise the precision of your estimates. So in OpenSAFELY, we set out to build something that could get access to data much faster and on a much bigger scale. But when you do that, you hit important challenges around privacy engineering. And also, for a long time, we've been very keen in my group to push forward the notion of modern open, collaborative, computational data science approaches, combining the best practice from the open source software development community, where people collaborate through services and tools like GitHub, sharing all of their code and code lists as they go, to create a library of analytic approaches and a library of code that can be efficiently reused by everybody who comes after you. And I've been very disappointed over the years by the extent to which health data and research in the UK has been held back by closed analytic approaches, people not sharing their code. So we wanted to build something that was large, highly secure and open. And that's exactly what we've done. So you can read the details at OpenSAFELY.org, and we've just had the green light to share lots more technical detail online. But essentially, working on behalf of NHS England, we've now built a full open source, highly secure analytics platform running across the full pseudonymized electronic health records of 24 million people, rising soon to 55 million people. That'll be 95% of the population of England. We've pursued a completely new model for privacy, security, to keep costs down, and for near real-time data access. We've built that analytics platform inside the electronic health record data center of the major primary care EHR providers. So that's the place where the data already resides. So we don't need huge, expensive extractions of data. In addition to that, we've built software that uses tiered and increasingly non-disclosive tables, which prevents researchers ever needing direct access to the most disclosive underlying data in order to run their analyses, but allows them to run code that addresses that most detailed data to make sure that the quality of the research is never compromised. And lastly, we've built a framework where your statistical analysis code and your dashboard code is developed against simulated dummy data using open platforms like GitHub before that analytic code is then pushed through to the live data environment. So that means you can develop all of your code in the open, you can develop your code using industry standard tools, but without ever compromising access to the data. So everything's run smoothly. We're fully live inside TPP. We're signed off with full data access and end stage tech development for the computational platform in EMIS. And our first paper, the largest analysis on COVID risk factors or factors associated with death from COVID ever conducted, has now been published in Nature with another dozen or so papers in end stage development. And you can see a longer list of research outputs, both ongoing and completed, at OpenSAFELY.org if you're interested. And we're also using OpenSAFELY to produce a wide range of live interactive dashboards on restoration of service in collaboration with colleagues from the NHS. And actually, that, I think, is where my heart really lies. I've been doing a lot of work recently on better use of data for kind of practical coalface analytics, looking at signals suggestive of variation in care. The use of data to improve quality, safety and cost effectiveness of care is a neglected space. And we did a paper in Journal of the Royal Society of Medicine recently, and if you have a kind of mail out that goes out after talks like this, I'll send you a link that you can push around in case there are people who are interested in that. Before we get to the super hardcore details, let me tell you very briefly about the data that's in OpenSAFELY. So we've got every individual patient's full pseudonymized raw primary care GP record. Everyone here I'm sure already knows, but that is all diagnoses, tests, referrals, prescriptions, linked onto their data from SUS, so that's hospital admissions and outpatient visits, ECDS, which is coded A&E attendances. ECDS is such a fantastic, pragmatic, stripped down data schema or data dictionary built with busy A&E doctors in mind. Just tick one of these 130 boxes, please. Matched on it, we've also got CPNS, which is the rapidly created death in hospital from COVID dataset from NHS England, which updates every day. SGSS, which is COVID test results. ONS, which is cause of death in and out of hospital. We've got household data, so we know about the other pseudonymized occupants. We know if it's a care home, we know the approximate location. We've got the ICNARC data, which is ITU. We've got, coming very shortly in a very good, strong collaboration, ISRIC, which is detailed hospital records of hospitalized COVID patients, and more. And despite this unprecedented scale of data, I'm very pleased to say that privacy advocates like MedConfidential have actively praised our privacy model. And that's because we've done it with people like them in mind. We developed it thinking, how can we do this in a way that doesn't result in large data downloads? The last thing to cover very, very briefly, but probably the most important part of the whole story, just to expand on Amir's soppiness about our team, this has been built as a truly collaborative project across a wide number of organisations. So my group at the Data Lab are reasonably unusual, and we are kind of the glue between traditional electronic health records research and pure software development. The developers and the chief medics at TPP and EMIS have been absolutely fantastic. I mean, it is a dream come true. EHR vendors and DHR researchers working alongside each other is a very under-ploughed furrow, and it's worked really well. We're also working in collaboration with the Electronic Health Records Research Group at London School of Hygiene and Tropical Medicine, led by Liam Smith. They are my lead brand for electronic health records research, especially primary care data. Primary care data, as everyone I'm sure here knows, can be very messy. It's created for the purpose of direct care. When you're using it for research, you've got to be really aware of the bear traps and the risks of doing that. And it's very easy to do terrible, bad quality research using GP data without knowing that that's what you're doing. So they've been fantastic. And then lastly, colleagues at NHSX. And as I said, we're doing all of this on behalf of NHS England. And that, I must say, has been an absolute dream. But it's a small team still. We are maybe 6 to 10 developers, depending on how you draw the perimeters. 6 or so developer researchers, people in the kind of crossover group, and 30 affiliated researchers. So let me tell you the meat and drink of how it all works. How long have I got? Just tell me quickly, Joe, how much longer should I talk for?
Maybe 10, 15 minutes.
All right, good. Okay, so first up, to understand the design choices we made, I think it's important to understand the risks of data sharing. We built OpenSAFELY to be as secure as possible to protect patients' privacy while allowing researchers to run analyses across an unprecedented scale of patient records. And in particular, we've chosen not to go down the traditional route of permitting researchers to download very large amounts of pseudonymized patient data onto their own local computers for analysis, whether that's a machine in their building or their own laptop. Now, the privacy problems we're aiming to overcome, I feel, are not adequately understood. We all understand that it's important to keep private medical information about identifiable individuals secure and confidential. But much of the way that we talk about it, and in fact some of our regulatory frameworks, don't really address the key challenge around re-identification of pseudonymized data. So people talk about pseudonymization as if that's sometimes the same thing as anonymization. You remove specific and extremely obviously disclosive pieces of information like the name, the calendar date of the birth, the last digits of their postcode. Now, the problem with this, as I'm sure most people on this call would know, is that records which have been pseudonymized are still very, very much vulnerable to re-identification. Now, of course, researchers and informaticians are trustworthy and they're carefully evaluated to be trustworthy. But to understand privacy and security risks, researchers talk about threat modeling. You work through worst case scenarios because you want to make sure that your security systems are as resilient as possible within reason. So with that in mind, here's an example of how you might think through the vulnerabilities of pseudonymization as it is traditionally done. If you know that someone had twins in 2013, another baby in 2014, and then moved from London to Oxford in 2015, that's my wife, by the way, that would probably be enough to uniquely identify them in a carefully pseudonymized GP electronic health records dataset, because there's probably only one person with those characteristics in the country. So having identified the pseudonymous identifier for that individual, you could then see all other aspects of their medical history that are also recorded in the same dataset, including things that you didn't already know about them. Now, importantly, the risks of re-identification from that kind of approach increase as your data set grows to cover a larger proportion of the total population. So let's say I had a 5% sample of the population, and with the 3 characteristics I know about my wife and who I'm trying to re-identify because I'm a creepy and disgruntled stalker ex-husband, I must find a better example that doesn't characterize me in those terms. With those 3 characteristics, if I identify just one person in my 5% sample, then I can only really be 5% certain that that unique match really is the person I'm looking for. all other things being held stable, because there might well be another 19 matches in the remaining 95% of the population that I'm unable to search across. If I've got data, however, on 100% of the population and I find one unique match for the characteristics that I know, then I can be absolutely certain that I found the target of interest. So that's one important reason why we had to up our game on privacy. If you have 100% of the population, then re-identification becomes much more straightforward. So that's enough, I think, to understand why we made some of the design choices that we made. Number one, as I said, we built the analytic platform inside the existing data center. So that's important. It means we don't transport large amounts of potentially disclosive pseudonymized patient data outside of those secure environments. Instead, we built the secure analytics platform in the place where the records already reside. Now that means trusted analysts can run analyses across data in near real time instead of waiting for intermittent data extracts. It means that you're already operating inside a highly secure environment, compliant with standards like ISO 27001. It means you can keep logs of every action on the data. It also avoids long and difficult and expensive data transfers. So the full records of the entire population of England, or at least the key subset of records that are useful for this kind of research and operational research, amount to probably around 100 billion rows of data. And that's information on a scale where it would take a long time to send it over even the fattest N3 pipe. Probably faster to drive to the data center with a hard drive on the passenger seat of your car, or at least back in the old days when we were allowed to drive freely around the country during pandemics. And overall, it means that people get access to the data, most importantly, without downloading it to their local machine where we can't see what they're doing with it. It also brings other less expected advantages. So, as I said, OpenSAFELY is a huge collaboration, working closely with the EHR vendors who bring an enormous amount of experience and expertise in this area because they build the software platforms that generate and manage the data in the first place, is actually really crucial and important. Now, that's not to say that we're wedded to only running OpenSAFELY as a code base and as an approach inside the EHR software vendors' data centers. We've written all the OpenSAFELY code to be portable, so it can run against any EHR data set in any secure environment, and that would include putative future central repositories run by the NHS or by the state more broadly. But as a basic principle, we think it's important that wherever possible, patient data should exist in as few places as possible, in the most secure environment possible, but with sensible access for researchers to safely analyze it in situ. So that's what a trusted research environment is traditionally considered to be, although we're seeing, to my mind, quite a frightening proliferation of trusted research environments, and we're seeing the phrase being used in quite a permissive way. I think what it would be good to talk about for the last 10 minutes or so is some of the ways in which OpenSAFELY has gone beyond just building a conventional off-the-shelf trusted research environment, which is basically like downloading the data but onto somebody else's computer that you remotely log into, and talk about how we've added extra features bespoke for electronic health records research, which help preserve privacy, but also, as I said, ensure that we have open, collaborative, reproducible and efficient ways of working with data. So first up, there's a long history of people making trusted research environments where people are assessed to make sure that they're safe to go in. And a typical model is that vetted researchers log into a remote desktop like Windows 7, and they have access to a standard familiar statistical analysis software package, RStudio, Stata, SAS, and the data set that they've requested on that remote machine's hard drive. You typically have some controls on removing bulk data from the machine, and activities generally monitored in some kind of way, but for example by recording a video capture of the screen in some cases. Now that's better than letting people just download data onto their laptops, but depending on the implementation, a lot of the problems from data downloads persist. It is like having access to the data on someone else's computer. So with OpenSAFELY, we've built something rather different. To explain why, because you're a nerdy crowd, I'm going to go into some painful details. So first up, we need to think through what are essentially the sort of 4 tiers of data that we operate on in OpenSAFELY. So level 1 is the raw GP data. So this is 1 row per event, and it'll go NHS number 979837413, name, Joe Jubbs, event, a 2-month prescription of Falalapril, 2 milligrams twice a day, a date and a time and a location where that took place. Then the next event code in Joe's record will have his NHS number, his name, then it'll have a diagnosis of asthma was made at this date and time. A potassium blood result came back and it was 3.9 on this date from this place. Now, that is obviously very highly disclosive. It's also very detailed. Traditionally, what people work across when they're doing electronic health records research is that but one step removed. So Joe Jumps' name gets taken off, his NHS number gets taken off, but it's replaced with a pseudonym, AJ583971. The location might be replaced as well by a pseudo ID for the practice or a medium super output area, some kind of region code. Now, here's where things start to get interesting for anybody who works on electronic health records for research. Typically, a researcher wants to run statistical analysis code like multivariable logistic regression across a data set that has 1 row per patient with variables describing various features of that patient. Now, those variables are much more sparse and therefore much less disclosive than the detailed information held on each patient's record. So, for example, you might say, has this patient had a high blood pressure recorded in the last 12 months? So to do that, you would say, OK, I'm going to get all of the event codes in SNOMED CT and CTV3 and READ for blood pressure measurement. I'm going to pull all of those. And for anything where the systolic is over 140, within the last 12 months, I'm going to say this person is a 1, a yes, for have they had high blood pressure in the last 12 months? And if they don't have that, then I'm going to say a 0 for no, they've not had a high blood pressure recorded in the past 12 months. Now, that is the meat and drink of electronic health records research. And people produce things like code lists that allow them to identify patients who meet certain characteristics. So, for example, you'd say, you know, anybody who's got a hematological malignancy, well, here's a great big long code list of all of the event codes that suggest that somebody's got a hematological malignancy, and that could be a diagnosis of the thing that you're interested in. It could also be a treatment code or an investigation code that it could only be associated with that particular condition. And you might just say, I'm interested in this code being present within this time range for this person. And if it is, then I'll make them a 1, not a 0 for having that disease. Or you could have some slightly more complicated logic. You might say, to say that they've got poorly managed diabetes, then they have to have diabetes diagnosis codes and these characteristics in their treatments. But fundamentally, that's all done with code lists. Now, typically, that's done behind closed doors on a researcher's own laptop with code lists that they make themselves. And if they choose to share them at a later date, then that's considered to be nice and sort of good practice that they posted them on a notice board or in an appendix. But that's about as far as it goes. Now, the way that we've built OpenSAFELY around that task, I think exemplifies all of the important characteristics about our privacy architecture, but also our open approach to analytics. To convert the raw pseudonymized event level data into a 1 row per patient data set, we've built an open source software framework where everything that you do is open, everything you do is standardized. First up, you can go and have a look yourself if you go to Open Code Lists or codelists.opensafely.org. You can see every code list that we've ever produced for everything that we've ever done. It's always, you know, you're in a good crowd when you can see people looking down and going to the web page. Codelist.opensafely.org, you can see every single code list we've ever produced. We don't post them there for purity. We develop the codes online at codelists.opensafely.org, and they are called from there by the OpenSAFELY software. You cannot drive OpenSAFELY without sharing your code lists in public as you go. You cannot drive OpenSAFELY without sharing your analytic code in public on GitHub as you go. Then you write some standard assertions, which are to make your, it's called the study definition. Can I post in the chat? Hang on. Oh my God, the chat's full of stuff. Wait a sec. OK, I'm just going to post the kind of code that you would type to make a variable for does this patient have COPD. So you can see it's all quite nicely readable code. You'd say COPD equals patients with these clinical events, and COPD codes calls COPD codes from OpenSAFELY code lists. You can see also crucially, that it says return expectations, incidence 0.15. What you're saying there is, I'm expecting the prevalence of COPD in the population to be about 15%. Now that's used in two important ways. Firstly, it's used to automatically sanity check your data set when you produce it. So that's really good. Best practice being embedded in the code that runs all of the whole analytics framework. But it's also used to do something else. It's used to generate the simulated dummy data. So when you've written your study definition, which is lots and lots of assertions like that about the patients in your data set, then the system running purely on GitHub, nowhere near the real data at all, just running purely on GitHub, using GitHub Actions at the back end, which is super cheap, it generates you a completely randomly generated simulated dummy data set that respects those assertions that you've made about what your data is going to look like. Now that is completely randomly generated simulated dummy data. It's not synthetic data. It doesn't respect the co-segregation of different variables in the population. It's not in any way disclosive, and you can't do any research on it. But what you can do is write your analytic code in Stata or R or Python against that dummy data on GitHub, and you can make sure that all of your analytic code will pass all tests. And that's a basic principle from software development, that you should have good tests on your data. When all of your code is running perfectly and doesn't hit any blockages as you try to run it on GitHub Actions against your dummy data, then and only then, when we know that you've got a working study definition and that you've got code that really can run against the data, then and only then does your study cohort extraction code and your statistical analysis code get pushed through into the real environment with the real data. It runs against that. It pushes out the results tables and the graphs into a folder. You look at those, make sure there's nothing disclosive in them manually, and then you press a button to export them out back to GitHub, and then you and your team and the world can see what it is that you've done. Now, just to reiterate the importance, and if you can forgive it, the elegance of what we've done there, the researchers are therefore allowed to run statistical analysis code against the full universe of data of all patients in the country, but they never need to go into a setting where they have the ability to do a naked SQL query against the underlying data. They never have the full power of a fully permissive database query against the entire nation's electronic health records. Now, I think that is... unknown participant is now exiting. I think that's, in its own small way, game-changing. And I feel that we're very keen to push this model forward, because I do not feel comfortable about anybody having access to the entire nation's electronic health records on any other terms, especially when it's not necessary for them to do so. And that's, you know, that's the argument that we will push. So that's OpenSAFELY. That's how we built it. That's how it works. And for those of you who are very, very, very nerdy, you need help from us for us to actually run your live code against the live data. But you yourself, if you know what you're doing, you can go to GitHub, you can clone our study definition repo, you can write your own cohort definition, you can generate your own dummy data, you can write your own statistical analysis code in Stata or R, you can get to the point where it's passing all tests, you can do everything yourself out in the open. And then the final step of it being run against the real data is, frankly, trivial. So we're working towards getting external people onboarded, to getting external researchers, and in particular, we're interested in operational research, NHS researchers. But I think I'll stop there because I've been rambling on for too long, and hopefully you've got questions. Is that all right?
Great, thanks, Ben. There is one question. It'd probably be easier for you to look in the chat. Can you see it?
Oh yeah, Kurt Wilson.
Right. Yeah, I'm not going to read it out.
I'm interested to see how real patterns within the data might be shown to influence decision making, i.e. when clinicians are presented with information within certain parameters in an electronic record, results, groups of conditions versus others, how that might translate into different. So I think, Kurt, you're talking about kind of decision support tools and pop-ups for individual clinicians. And that's something that we're really interested in. That's kind of a separate thing to this, but we've done some research on it recently. Actually, we published a couple of papers looking at different prescribing behaviours in different GP practices, breaking down the behaviours by which electronic health record system is used in each practice. And what's interesting about that is that you can see different behaviours. So we found that there was a particular problem, about £12 million a year being spent on needlessly expensive branded generics. So a specific, you can specify the brand of a generic, but in a way that doesn't really get it coded properly as a generic, and people weren't noticing. And people were losing about 12 million quid a year on that. And we saw that it was principally only happening in practices using System 1 TPP software. And we went out and we tried to prescribe the thing that was being prescribed, where we saw the problematic signal, and we found we could see from the interface why it was in the picking list that people were making that choice. So we got in touch with System 1 and they changed it incredibly quickly, and now we can see that the number of prescriptions for branded generics of atorvastatin, for example, are dropping precipitously. So there's no doubt that the way you present information makes a really big difference, and we're really keen to start building a kind of a research community around that kind of practical aspects of EHR system design. And if anyone's interested in any of that, then please get in touch. Any email you find from me on the internet will get to me straight away.
So next question, any plans to include Wales data?
Look, the smaller nations of the UK, I think, don't bring a lot in terms of statistical power, but they do bring a lot in terms of relevance, and also sometimes you can be agile in different settings. We've worked very, very hard to try and get Openprescribing.net built in Wales, Scotland and Northern Ireland. Whenever we've spoken with people, and we've had, I would say, at least 5 meetings with Wales, at least 3 with Scotland, they've always concluded that it would meet their organisational and cultural requirements better if they tried to build it themselves. And we think, that it would be better to reuse open code. That's why we give everything away. I think that's always a struggle with doing work in Wales, Scotland and Northern Ireland. I think also there are sort of interesting cultural challenges around giving stuff away. Open source tools are quite an interesting challenge to public sector for procurement in particular. Understanding the value of free, and also understanding that it needs to be resourced somehow, but it's not held behind a paywall where it's transactional. Give us the money and we'll let you see your data. But look, we'd love to build OpenSAFELY for Wales. It's just a matter of, I think given our previous efforts with open prescribing, it would be very much that we would wait for other people to come to us, but we're always open to discussing that kind of stuff. Somebody wants the URL, that's opensafely.org.
Next one, code list builder function available to all.
Okay, so really important. If you want to build code lists against primary care data, you don't need permission from me. Go to codelists.opensafely.org. You can reuse the ones that we've made and you can build your own. Right now, because we don't have just person time resource to manage opening it up completely to anyone and then manage logins for people, you'd have to ping me an email. But ping me an email and we'll give you a login, and you can use codelists.opensafely.org. And it's very much on our roadmap that's open to all. And we're really excited about people using the code list builder for their own projects. You can make API calls to it so that you can integrate it fully into your code. We've been talking to various people, including Merlin Dunlop, who does some great stuff with pop-ups and templates in primary care for, it's not Ardens. Oh, I think they have been bought by Ardens. It was Quaff Masters, and they've now become the sort of EMIS bit of Ardens. But yeah, he's really keen to use it as well. So we're really keen to have anyone using it. And also, if you're an analyst in Oxfordshire CCG, you should have already emailed us. Get in touch, and we'd love to do stuff with you.
And I can say the code list builder is really intuitive. It's fantastic. The team's design, someone like as a clinician, you'll find it really helpful to go down and all. demonstrate the different relationships. So it's definitely worth a look. So the next question, any plans for linking in hospital electronic prescribing data?
Yeah, look, we can, it's very straightforward for us to link on to other data sets. It's a question of what are the benefits, and then what are the technical, regulatory and cultural barriers. And by cultural, I mean, organizational, political, that sort of stuff. I think for hospital prescribing data, that's a long way behind primary care prescribing data. Hospital EHR systems in general in the UK are, it's a real patchwork. It's, the primary care is the right place to start for a national view. It's one record per person. It's also a gloriously simple data schema. So there might be different data dictionaries kicking around, like CCV3, READ, and SNMED CT and whatever. But it is fundamentally in its structure a list to which new events are appended, whereas hospital data systems are much messier than that, and all efforts to produce national standards are much more challenging. But look, we would be very happy to pull in electronic prescribing data from hospitals. We've managed to, we ran a campaign really to get the aggregated by month and by trust hospital prescribing data, which we're just about to start producing tools on as part of Openprescribing.net. And that's being shared as open data. We published a paper in the BMJ recently, which I'll find the link and send it around, on why that should be made publicly available. And I'm pleased to say that since our paper came out, it has now been shared.
Cool.
Yeah.
Okay. Let's move on to the platform and ethics approval. Does OpenSAFELY require ethics approval from NHS recognised ethics committees?
Well, so the only researchers working on OpenSAFELY at the moment are the OpenSAFELY team itself. So we're working on behalf of NHS England under contracts with NHS England, and we obviously have ethics approval from HRA and from Oxford and London School of Hygiene ethics committees. Yeah.
Do you have any plans to link medical imaging data?
Look, we can do all of this stuff. It's just a matter of the costs, the benefits, and again, it's about the technical, regulatory, and cultural barriers. Imaging data. We have thoughts and plans around a TRE for imaging data. I think that might be quite. It's potentially quite a populated space. There are kind of there are often centres of gravity in medicine and in medical data science, where there are people who are very well resourced with a very kind of specific view of how things can be done, where it's less straightforward to come along with another option. I think there's a huge amount of investment on AI in the UK at the moment, which I'm fully behind, although I think I'd put CSVs before AI if you're wanting to optimise the logistics of healthcare delivery and improve quality, safety and cost effectiveness, although undoubtedly, there's a really important role for AI, and in particular in imaging. I suspect that sort of analysis frameworks around imaging to support AI will be very well resourced, and I don't know whether they'll follow an open model. I hope that they do. I don't think it would be. I don't think it would be the path of least resistance for expansion of the OpenSAFELY model, I guess. But I don't know. I haven't evaluated it closely. And they're all, all the people I've seen working in that space are fantastic. It's just a question of different approaches. Incredible platform because of the messiness of EHR data. Often there's a lot of debugging needed to catch outliers, harmonise codes. Presumably some of that can be predefined, like the check without the need for case review. But as analyses get more detailed, how do you think we can grapple with this debugging issue in a blinded research environment? So that's really important, and we do that at scale. We do that by doing sanity checks. So, for example, you can try and compare what you know about individuals from one realm in a completely different data set. So, for ethnicity, for example, you can do two things. primary care ethnicity data is present for about 70% of people. First of all, if you compare the proportions of the missing and the present code, so the 70% of people where you know their ethnicity, you can see that the proportions for each ethnic group are the same as what you see in the census. And the census is the gold standard. I do believe the census for the proportion of the population and in different parts of the country that are Bangladeshi, or in the super category South Asian, or white British, or white Irish. And so we can be fairly confident that that data is broadly missing at random. You can also do sanity checking at the level of individual patients. So you can say, well, some people will have ethnicity coded in HES, some people will have ethnicity coded in primary care. How often are there disagreements between the two? However, you've got to be super cautious, super thoughtful, because you don't want to, for example, say, let's just take the ethnicity data from primary care and from HES and add them together, because that will bump it up to beyond 70. Because the problem with that is then you start introducing bias potentially, because it means, for example, you have better ethnicity data on the subset of the population who are unwell enough to have hospital attendances. So we address all of this stuff with sanity checks and with cross checks in the data. And one aspect of our working model, which is obviously very, very, very open by design for efficient reuse by others, as well as so that people can check our mistakes, improve our code, and also to generate or to solicit and invite public trust. We're also sharing the intermediate components of all of our analyses. So it's very common to read a journal article about some electronic health record research where they say, all the data was checked and it was all fine, basically. Or, we did sanity checks to ensure that there were no variables and we cleaned the data using something, something, something. With us, you can see all of our code that we did to sanity check the data. You can reuse it yourself, right? For anybody coming after us who does research using the OpenSAFELY platform, and we hope that there will be hundreds or thousands ultimately, we're turning the routines and the code and the libraries that we use to do sanity checking on data for one purpose. The first time you do it, we don't just run that code and then throw it away. We take that code and we turn it into a library. And what that means is that we are embedding the expertise and the knowledge of all of the electronic health record researchers who work in the platform. We are embedding that in code for other people to then use. I think, this is not a prop. This is a pair of nail scissors on my desk. It's multitasking, cut your toenails whilst doing a seminar. Now, imagine a world in which everybody had to invent a pair of scissors from scratch every time they wanted to cut a piece of paper. That'd be ludicrous, right? Scissors exist, you grab them off the shelf, you use them. Whenever you try and do DIY, you Google it, you find out that there's something called a jigsaw. I had no idea. Turns out you can use that to mash the back off some shelves and get it on, right? Every time we make a tool to do one job, we don't just keep it for ourselves and we don't throw it away. We store it carefully and we make it available for everybody to use next. And as part of that, we're not just sharing it in code, we're also going to start sharing what we're calling OpenSAFELY short data reports. And that will be not the big headline papers, not the papers that go in Nature saying, people with hematological malignancies are X times more likely to die of COVID, but rather it is the sanity checks. We've got 70,000 patients from ISARIC, the prospective research data set on people admitted to hospital with COVID. And we've got many, many, many more people admitted to hospital with COVID in SUS, in the administrative data. To what extent do they overlap? To what extent are they similar and dissimilar with respect to the demographics, with respect to the odds of subsequent death in hospital from COVID or death out of hospital from other causes, their previous medical history? Are the people in ISARIC sicker or less sick? Are they more likely to be white? Are they more likely to be men? Are they more likely to be old? Now, that's actually very useful information for the people at ISARIC, for anybody ever using ISARIC ever again, for anybody using ISARIC in OpenSAFELY, for anybody who's using OpenSAFELY, as we are now, to follow up hospital admitted patients in their electronic health record data, which we're doing for National Core Studies, for Government Office for Science and Patrick Vallance. That intermediate output is actually a really powerful thing to share. So we share it on GitHub, we share it as a short paper, but we share it as a library that other people can use.
Ben, moving on to teaching. Can the platform be used in any teaching context? For example, use of simulated data?
Well, look, I mean, you can...
As real data rather than simulated data.
Yeah, you're very welcome to go and use the simulated data, and I think it would make a really interesting sort of case study and exercise on any computational data science modules for electronic health record research. The real power of our open way of working, I think, is in capacity building, which I alluded to at the beginning. So in our group, we've got, as I said, traditional academic researchers, clinicians and software developers. We've also got essentially policy wonks, and they come to us knowing nothing. So there's a guy called Brian McKenna, stage hypnotist. No, that's another. Anyway, Brian McKenna was previously a clinical fellow working for Keith Ridge, chief pharmacist at NHS England. So he was a pharmacist, CCG pharmacist, then working in a policy role. He came to us on a short-term basis to just kind of learn what we do and how we work. Within 6 weeks, he was writing his own Jupyter notebooks. Now, a Jupyter notebook is an incredibly powerful way of sharing what you've done, an incredibly powerful way of doing the analysis work in itself, but also an incredibly powerful way of building capacity. So for those who don't know, a Jupyter notebook is, hang on, let me see if I can find one to share. Oh, I haven't got time. Look, a Jupyter notebook is essentially a document where you have 3 types of cell as you go, right? So a traditional academic research paper, it's just got text and tables and graphs, and then some references at the bottom. In a Jupyter notebook, you have text and headings, nicely formatted text, where you might write the title and the authors and the background to the project. But then you can also have blobs of code and then blobs of the output from that code. Now that's really powerful because it means you might say, this is a notebook to look at how we can use the Data Lab change detection library to identify the practices within CCGs who've done the best at reducing their opioid prescribing over the course of the last 12 months. And so you'd say, first up, I'm going to extract all of the opioid prescribing for every practice in every CCG in our region. And then you have the code that does that job in a SQL query against our BigQuery database in that case. And then you'd have the line of code that says, display the first 5 rows of that table, just so I can eyeball it and make sure it's okay. And then you'd have some free text. You'd say, next up, I'm going to import the Data Lab change detection library, and I'm going to run it across everything. And I'm going to test that it's generated graphs by making sure that there are some images in this folder. And then after that, it will execute. Then you write the code to actually do that. And then you'd say, display the first 3 images. And then you'll see the first 3 images, right? Now, when somebody joins our group, as people increasingly are, we ask them to do 2 things at the same time. Number 1, they go and do a generic Python for data science course that we have selected. There's one on Code Academy that's really good. And if you block out your diary, you can finish it before the end of your 7-day free trial, because we don't have any money. No, people don't give us money. It's annoying. There you go. So you can do the Code Academy Python for data science course. But at the same time, you also have one eye on a Jupyter notebook from our group, which is on the sort of thing that you're already interested in, because that's why you're coming to work with our group. Now, that's really powerful because it means that you are learning about Python for data science in general, but you're also looking at this worked example in the adjacent window, which is exactly the kind of analysis you're going to do in the future on exactly the data that you're going to be working on in the future. Now, previously, we've done that with the prescribing data, and it's worked really well. What we're doing now, onboarding, in particular, I'm extremely excited about operational research folk for the NHS, people looking at restoration of health services and variation in care and opportunities to improve safety and quality and efficiency. We've got people who are looking through Jupyter notebooks that are running across the entire universe of the entire nation's electronic health records. Now, I don't, I don't think I've got the words to express what an extraordinary thing that is, what an extraordinarily powerful thing that is, because it means that we now have the possibility of a world where people can write their scripts as a CCG analyst or an ICS analyst or an analyst in a national setting to identify problematic use of potassium tests or any of the other things that we might want to go out and offer people help on, and try and understand what the issues are. If everybody's writing that using the same framework and in the open on the same platform against the same underlying data, then the scale of the efficiency, the reduction of duplication of effort, of openness and of sharing and of capacity building as everybody builds alongside everybody else, I think is truly phenomenal. And that's the world that we want to see. That's the world that we want to help on. And there's only really one reason why I'm here. It's not to show off. It's because I want anybody who's on this call who thinks that sounds useful and interesting and fun, I want you to email us, and I want you to come and join us. And I want people clamoring on our door to be able to do their own work in OpenSAFELY, and we'll find the people who are closest, because we're slightly short of person time at the moment, the people who are closest to being able to drive the machine themselves, and we will clamour on the doors to get you in and to get you working on it as far and as fast as we can. We really want to find either a CCG or an ICS team who've got folk who are kind of a good bet for being able to work with Python, SQL, understand at least what YAML is, R, Stata, Jupyter notebooks. And if nobody emails me, I'll feel very, very sad.
Right, I think we've come to the end, but there is one other question. I don't know if Joe and Ben, you have time in case other people want to drop off and get to their meetings, that we do this one last question. Do you have enough time, Ben?
Yeah, sure.
Okay. My interpretation, I'd read it. It's Kurt Wilson's last question.
That sounds like it's final.
Yeah, Kurt, yeah, no more questions allowed. My interpretation is about, can we show people the data in OpenSAFELY, but somehow change it so it's not about real individuals, to help clinicians and who are learning about data understand the kind of noise that it generates. So they're learning about data in principle.
So I think what Kurt's alluding to is something called synthetic data. So what we produce in OpenSAFELY for people to generate their code against is very deliberately simulated data. It's dummy data. It's completely randomly generated. So it doesn't respect co-segregation of different features. Now, synthetic data does respect the true co-segregation. It adds some noise to real data. And it's a very interesting and fast-moving corner for research, because the objective is to permute the underlying data such that it's no longer disclosive, but whilst respecting the co-segregation of features in order that you can still use it to meaningfully generate research. So, for example, you might want to, you might every now and then permute somebody's ethnicity, randomly change their ethnicity, but preserve the finding that people from South Asian background are more likely to have diabetes. Now, the problem with doing that is you might want to take different synthetic data approaches to preserve different co-segregated features in the underlying data. There's a lot of issues around re-identification attacks, especially with multiple generation of the underlying synthetic data set and so on. All of that said, I think it would be useful to have a national synthetic data set, perhaps just a one-off dummy training set that could be produced to various specific criteria, simply for the purposes of teaching people how to use either OpenSAFELY or a tool like OpenSAFELY in the future. However, the overall objective of OpenSAFELY is, as I'm sure the more technical among you can see, to find a way that people can run analytic code without having fully disclosive access to the underlying universe. Now, we're never going to give vast, well, you know, the state, the world, the system is never going to give people access to the true data for frippery, for training, and in vast quantities. However, I think there is a sort of halfway house between synthetic data and simulated data that could be really powerful for training, but it's something where you need to tread extremely cautiously, and it can be quite costly. Hey, look, my email address is ben.goldacre@phc.ox.ac.uk, or you can do team@opensafely.org. And if it's not for work stuff, ben@badscience.net. That's probably more memorable. Any email address you find for me anywhere on the internet, it'll get to me. If you send me a crazy email, I might not respond. If you send me a work email, it might take 3 months like it did with Amir, but it will probably be quicker, and we'll read and reply to everything. Nice to meet you.
Thanks very much, Ben. Joe, thanks for inviting us to talk about OpenSAFELY today.
No, it's been great. No, it's been fascinating. Yeah, thank you for joining, Ben and Amir, and yeah, and as I say, I can pass Ben's email on if people want to contact me as well, and there'll be a recording of this available afterwards as well. So yeah, no, thanks.
Will it be publicly available? Can we make it publicly?
Yeah. Well, we can put it up on the faculty site, so it'll be available.
Well, only if you'd like to. Let me have a look and make sure I didn't say anything dreadful.
Yes, I'll send it beforehand, but yeah, we put them up there anyway, so that's the regular thing. Okay. Brilliant.
Hey.
Bye bye everyone.
Thanks so much.